दिल्ली, दिवाली और दिसंबर, कुछ याद आया? ये कॉम्बिनेशन किस चीज का है? दिस इज वन ऑफ दोज deadliest combination that affects your respiratory. जी हाँ, vital organ, respiratory system, vital system. और chronic respiratory diseases have been globally third leading cause of death. इतना ही नहीं, almost 81 million people in US suffer from one or the other respiratory diseases, and in India almost more than 15% of people suffer from the respiratory ailments. Now basically अगर आप देखेंगे तो सिर्फ एलर्जिक राइनाइटिस यानी नाक बहना, सर्दी, छींके आना, अगर सिर्फ इतना सा एक बीमारी पे पकड़ा जाए तो ग्लोबली ऑलमोस्ट 10 to 30% of the population globally is affected by this illness recurrently, chronically और intercurrently. इसका मतलब ये हुआ कि respiratory disease system itself is not only vital for a human to survive, but also very vital to understand that system for a physician. And you see, when it comes to respiratory, the definitive statistics of infectious diseases that does exist, but also huge number of statistics that does exist for the allergic part of it. और जब allergic part किसी भी बीमारी में आता है, तो which system better than homeopathy? Yes, this is Dr. Rashmi Shukla, founder of HomeoED. और हम इसी रेस्पिरेटरी सिस्टम में आपकी एक्सपर्टीज और हमारे स्टूडेंट्स जो रेस्पिरेटरी एनाटॉमी में, फिजियोलॉजी में, पैथोलॉजी में, मेडिसिन में पढ़ रहे हैं और साथ ही अप्लाइड साइड ऑफ ऑर्गेनन, मटेरिया, मेडिका, रेपर्टरी में जो पढ़ रहे हैं, उसका केस बेस्ड एप्लीकेशन करने का एफर्ट है. इस सीरीज में लास्ट ईयर हमने डर्मेटोलॉजी लिया, इस साल हम लोग रेस्पिरेटरी सिस्टम, इस महीने इनफैक्ट हम लोग रेस्पिरेटरी सिस्टम ले रहे हैं और अगले महीने हम कार्डियोवास्कुलर सिस्टम लेंगे. इन सारे वेबिनार्स का, यूट्यूब लाइव का जो मिशन कमिटमेंट यही है कि आप लोगों को अप्लाइड साइड पता चले कि कोई भी सिस्टम का नॉलेज का एप्लीकेशन इन होम्योपैथिक पर्सपेक्टिव कैसे करना है, कैसे सीखना है, कैसे समझना है और कैसे अप्लाई करना है. नाउ अब ये जो वेबिनार हो रहा है, ये लाइव वेबिनार हो रहा है, ये इट इज सुटेबल फॉर स्टूडेंट्स, इट इज सुटेबल फॉर फिजिशियंस एंड इट इज ऑल्सो सुटेबल फॉर to an extent to common public, so that they understand that how homeopathy is effective and how homeopath treats a case, understands the case. तो यहाँ पे हम शुरुआत करेंगे. हमारे एनाटॉमी के स्टार टीचर डॉक्टर आनंद पटेल विल बी टेकिंग केयर ऑफ द एनाटॉमी ऑफ द रेस्पिरेटरी सिस्टम एंड अप्लाइड एनाटॉमी एज वेल. उसके बाद में डॉक्टर पुष्पा शर्मा मैम, शी वुड बी टेकिंग केयर ऑफ physiology of respiratory system. Then we have a very wonderful teacher, Dr. Aarti Bansal ma'am. She'll take care of pathology and differential diagnosis of respiratory diseases, various respiratory diseases of course. Then there come the homeopathic side. The moment pathology, the allied side of the pathology is understood, the homeopathy side of pathology, that is miasmatic evolution and understanding of respiratory case from homeopathic point of view, that is philosophy point of view, who else are best selling and best teacher of organon, Dr. Nadia Babu sir. उसके बाद में now we have understood the pathology side, we have understood the homeopathy side, now we have to understand the like management part of it also. So we have got Dr. Yogita who would be taking care of the medicine, emerging differential diagnosis and exactly the investigating the patient, examining the patient. Now the end may, now it has to be treated. So here our Dr. Amisha will be taking care of repertorial side of respiratory illnesses. What are those commonly used medicines? Which medicines are used high on various respiratory illnesses? Dr. Amisha will be taking care of that. And materia medica, क्योंकि अब तो मैनेजमेंट भी करना पड़ेगा, तो what are those top ranking homeopathic remedies that are used and applied for management of respiratory diseases at large? That would be taken care of by our lovely teacher of materia medica, Dr. Soni Gupta ma'am. So buckle up your seats, get ready for the roller coaster of this respiratory system where you understand and learn to manage respiratory system homeopathically.
Welcome to the sequel of an historic event where the and legends of homeopathy from all over India will gather and share their subjective view on the respiratory system. So buckle up and get ready for HomeoED presents Webinar Reloaded, Episode 2.0 streaming live, November 26th, Sunday at HomeoED's official YouTube channel.
Hi, Dr. Anand Patel for Respiratory System Webinar Anatomical portion. Happy New Year, Nutan Varsha Abhinandan. In a respiratory system, there is an exchange between respiratory gases, that is oxygen and carbon dioxide, at the respiratory unit that consists of capillary at the one end and epithelium of alveoli at other end with common basement membrane. For this, respiration is required, that is inspiration and expiration. Inspiration and expiratory movement takes place through the muscles known as diaphragm and intercostal muscles mainly. This gas is exchanging between atmosphere and alveoli through an passage that is known as a respiratory passage. That this respiratory tract is divided into two parts. Anatomically it is known as upper respiratory tract and lower respiratory tract. That demarcation lies at the level of cricoid cartilage. In a figurative way, you can see this lower respiratory tract. For upper respiratory tract, you have to refer this proper type of picture where nasal cavity, oral cavity, pharynx and larynx refers to the upper respiratory tract, whereas your lower respiratory tract is below the cricoid cartilage, that is whole trachea, primary bronchus, secondary bronchus, tertiary bronchus, and further down it is known as a bronchial tree completely and ends in a microscopic structure known as alveoli. This is the lower respiratory tract. And as far as anatomical difference is concerned, the right lung and left lung can be identified through its borders. As in this specimen, you can see the anterior border is very sharp, whereas posterior border is, you can say, rounded, and base is hemidome shape and apex is truncated. Beside that, the medial and lateral surface. Medial surface has a characteristic hilum. You can see the root of the lung, or you can say hilum on the surface of the lung. And as this also very evident that right lung is short and the broad, left lung is narrow and taller. And as a rule, here in right lung you can see the two fissures and the three lobes, whereas left lung as a rule shows the one fissure and the two lobes. As a rule, why I mean to say, rarely opposite is also true. The side is to be determined always through the thin border anteriorly, rounded posterior border, apex and base, and through the hilum which is on the medial surface. And then you can see whether this given specimen follows the regular rules or not. Now, regarding your respiratory exchange, you can see here a microscopic structure, alveolus, where with the help of capillary you can see the exchange of the oxygen and carbon dioxide across the respiratory membrane. Now, this right lung and left lung, beside its anatomical difference, shows the one notch, that is in between the two lungs there is a heart, and in lower part it shows on the left side a cardiac notch. That is also very characteristic. And as far as the various diagnostic condition is concerned, as far as inflammation of nasal mucosa is concerned, it is known as rhinitis. Inflammation of the pharyngeal mucosa is known as pharyngitis. Inflammation of the, you can say, larynx is known as laryngitis. And in between there are adenoids and the tonsils and you can say paranasal cavities. So sinusitis, tonsillitis, rhinitis. These are also all as upper respiratory tract conditions, whereas lower respiratory tract condition includes tracheitis, bronchitis, tracheobronchitis, and further down in the parenchyma of the lungs you may have diseases like pneumonia, tuberculosis, lung abscess, or at the last very degenerative condition known as a bronchogenic carcinoma. Now this pathological condition may have a laterality. So as far as anatomy is concerned, I like to describe the side affinity. As far as anatomy is concerned, the remedies can be recalled in a right-sided affinity are the chelidonium and the bryonia, whereas left-sided is the natrum sulph. In Allen's keynote, it is known as a psychotic pneumonia, or you can say pneumonia of the left-sided lung, clearly mentioned in the Allen's keynote. And you can further narrow down your selection as per the number of the, or you can say, lobes in upper lobe right side, middle lobe right side, lower lobe right side. Similarly on the left side, upper lobe, lower lobe, and you can make the connection with the therapeutic aspect with this anatomical reasoning. Now this respiratory tract is also having a autonomic control. It is, you can take the breath voluntarily as well as it is a subconscious process. So this trachea, which has the trachealis muscles posteriorly, is under the influence of the autonomic nervous system, and that muscles is contract under the parasympathetic stimulation, whereas they get dilates with the sympathetic stimulation. So for the bronchial asthma, when there is a spasm of this bronchial tree, any sympathomimetic substance will be helpful. So your drugs like stramonium, hyoscyamus, they contains just like belladonna, atropine in them, alkaloid, and this atropine is sympathomimetic in nature, and that's why they are good bronchodilator. And when there is an allergic response or when there is a parasympathetic response, this bronchial tree undergo the spasm and it leads to the hyperventilation. The status asthmaticus or asthma can be revert back with such therapeutic approach. Lastly, the certain features, say in apical region, if cotton wool appearance is there, it is refers to the tuberculosis mainly. If there is a brown glass appearance in any zone of the parenchyma, then it is referred to the pneumonia, or you can say alveolitis. So this is my brief submission, right from definition of respiratory system, its subdivision upper and lower respiratory tract, then giving the idea regarding the what is the mechanism of the respiration, that is what are the muscles are utilized, and lately how the therapeutic approach is there anatomically as well as in a, we can say, nervous system, how they controls your hyperventilation state. In a pneumonia there is a high grade fever and the hyperventilation that is to be mentioned. So along with the applied aspect, we had concluded our respiratory system webinar, especially the anatomical portion. Rest physiological and clinical portion will be continued. Thank you.
Good morning class, this is our new anaphysio class in which today we will study about the remaining portion of respiratory system, in which today we will study about the control of respiration. देखिए हम लोगों ने रेस्पिरेटरी सिस्टम के एनाटॉमी पढ़ ली थी, फिजियोलॉजी पढ़ ली थी, हमने पढ़ा कैसे गैसेस का एक्सचेंज होता है, कैसे O2 पिक हुई, डिलीवर हुई, कैसे CO2 पिक हुई, कैसे डिलीवर हुई, पार्शियल प्रेशर जो है या प्रेशर ग्रेडियंट की हम बात करें तो एक्सटर्नल कितना है, इंटरनल कितना है, कब गैसेस एक्सचेंज होती हैं, कब बाहर से अंदर आती, कब अंदर से बाहर जाती, सब चीज़ें पढ़ी हमने। पर इस रेस्पिरेटरी पूरे प्रोसेस को, इस मैकेनिज्म को कंट्रोल कौन करता है या कैसे किया जाता है, वो हमें आज पढ़ना है। तो ऑक्सीजन डिमांड जब चेंज हो रही होती है उसके अकॉर्डिंग ही रेस्पिरेशन का कंट्रोल चलता है, जिसके अंदर कार्डियोवैस्कुलर और रेस्पिरेटरी रिस्पॉन्सेस दोनों का रोल होता है। इन दोनों पे डिपेंड कर रहा होता है लोकल कंट्रोल ऑफ रेस्पिरेशन एंड कंट्रोल बाय ब्रेन रेस्पिरेटरी सेंटर। हमारे लोकल पार्ट भी रेस्पिरेशन को कंट्रोल कर रहे होते हैं, वो लोकल एरिया भी, और ब्रेन में जो रेस्पिरेटरी सेंटर होता है वो भी इस पूरी मैकेनिज्म को कंट्रोल करता है। अब लोकल कंट्रोल कैसे होता है रेस्पिरेशन का? जब आर्टरियोल की जो सप्लाई है पल्मोनरी कैपिलरीज़ की, वो कॉन्स्ट्रिक्ट हो जाती है जब ऑक्सीजन लो हो जाएगी। जब भी आपकी ऑक्सीजन की डेफिशिएंसी आपकी बॉडी के अंदर होएगी, उस समय जो आर्टरियोल्स पल्मोनरी कैपिलरी को सप्लाई कर रही हैं वो कॉन्स्ट्रिक्ट हो जाती हैं, और ब्रोंकियोल्स जो हैं वो डायलेट हो जाते हैं जब CO2 हाई हो जाता है। ऑक्सीजन लो होता है तब आर्टरियोल्स कॉन्स्ट्रिक्ट हो जाती हैं, और जब CO2 हाई होता है तब ब्रोंकियोल्स डायलेट हो जाते हैं। तो ये तो है लोकल कंट्रोल रेस्पिरेशन के, उस लोकल एरिया में आर्टरियोल्स कॉन्स्ट्रिक्ट और ब्रोंकियोल्स डायलेट। तो ये तो उसी जगह की बात हुई। अब ब्रेन रेस्पिरेटरी सेंटर में क्या होता है? ब्रेन स्टेम में जो रेस्पिरेटरी सेंटर्स है उसमें 3 पेयर्स ऑफ न्यूक्लियाई पाए जा रहे हैं। 2 पेयर्स पॉन्स में होते हैं, 1 पेयर मेडुला ऑब्लंगेटा के अंदर पाए जाते हैं। हमारे ब्रेन के रेस्पिरेटरी सेंटर में न्यूक्लियाई के 3 पेयर्स होते हैं, 2 पेयर्स पॉन्स में, 1 पेयर मेडुला ऑब्लंगेटा के अंदर। ये रेस्पिरेटरी मसल्स को कंट्रोल करते हैं और वेंटिलेशन की रेट और डेप्थ को सेट करते हैं। रेस्पिरेटरी रिदमिसिटी जो है, रिदमिसिटी सेंटर है, वो हमारे मेड्यूला में पाया जाता है कि रेस्पिरेशन की रिदम कैसे चलेगी, सही चल रही नहीं चल रही। अगर बढ़ जाती है टेकेपनिया, कम हो जाती है ऑर्थोपनिया, बहुत कम हो गई डिस्निया, ये अलग अलग कंडीशंस हैं। ये कौन सी कंडीशन? जब रेस्पिरेशन की रिदम बिगड़ जाती है, और इस रिदम को कंट्रोल करने वाला सेंटर जो है वो मेड्यूला में पाया जाता है, जो कि हमारे ब्रीदिंग की बेसिक रिदम को सेट करता है। अब ये रेस्पिरेशन पैटर्न का बेसिक रेगुलेटरी प्रोसेस यहाँ पर बताया गया है। इनहेलेशन और एक्सहेलेशन। इनहेलेशन 2 सेकंड्स और एक्सहेलेशन में 3 सेकंड्स लगते हैं। देखिए यहाँ पर डॉर्सल रेस्पिरेटरी ग्रुप जो है वो एक्टिव हो जाता है। जैसे ये ग्रुप एक्टिव हो जाएगा, हमारे इंस्पायरेटरी मसल्स कॉन्ट्रैक्ट होंगी, जिससे इंस्पायरेशन का प्रोसेस होएगा, और जैसे ही आपने इंस्पायरेशन किया, ऑक्सीजन को अंदर लिया, वैसे ही डॉर्सल रेस्पिरेटरी ग्रुप जो है वो इनहिबिट हो जाएगा। इनहिबिट होते ही इंस्पायरेटरी मसल्स रिलैक्स हो जाएंगी और पैसिव एक्सपायरेशन हो जाएगा। जब इंस्पायरेटरी मसल्स कॉन्ट्रैक्ट हुई तो इंस्पायरेशन हुआ था, जब इंस्पायरेटरी मसल्स रिलैक्स होती हैं तो एक्सपायरेशन होता है। एक्सपायरेशन होते ही सारी CO2 जो है वो बाहर निकल गई, गैसेस बाहर निकल गई, वापस आपका डॉर्सल रेस्पिरेटरी ग्रुप एक्टिव हो गया। ग्रुप एक्टिव होते ही वापस मसल्स कॉन्ट्रैक्ट होंगी, ऑक्सीजन को अंदर लिया जाएगा। तो ये पूरा प्रोसेस कहलाता है क्वाइट ब्रीदिंग। हमने 2 तरह की ब्रीदिंग पढ़ी थी ना, उनमें से पहली है क्वाइट ब्रीदिंग, जिसका ये मैकेनिज़्म बताया गया, और आपको ये डायग्राम, ये फ्लो चार्ट जो है वो एग्ज़ाम में बनाना है। ठीक है। अब दूसरा फोर्स्ड ब्रीदिंग। फर्स्ट थी कौन सी थी भाई? क्वाइट ब्रीदिंग, जिसमें कैसे हम इंस्पायरेशन कर रहे हैं, कैसे हम एक्सपायरेशन कर रहे हैं, जिसमें रेस्पिरेटरी ग्रुप, डॉर्सल रेस्पिरेटरी ग्रुप का रोल बताया गया था और मसल्स का। अब फोर्स्ड ब्रीदिंग के अंदर हमें क्या करना पड़ता है? तो DRG जो रेस्पिरेटरी गैसेस हैं आपके, उनकी डिलीवरी के बारे में बताया गया है। इंस्पायरेटरी सेंटर जो आपके VRG में है, डॉर्सल और वेंट्रल रेस्पिरेटरी गैसेस के बारे में बताया गया। तो इंस्पायरेटरी सेंटर जो है वो एक्टिव हो जाएगा और एक्सपायरेटरी सेंटर इनहिबिट हो जाएगा। एक्सपायरेटरी इनहिबिट हो गया, DRG, इंस्पायरेटरी सेंटर वगैरह एक्टिव हो गए। जैसे ही ये एक्टिव हो गए तो इंस्पायरेटरी मसल्स कॉन्ट्रैक्ट होंगी, एक्सपायरेटरी मसल्स रिलैक्स हो जाएंगी। इंस्पायरेटरी कॉन्ट्रैक्ट, एक्सपायरेटरी मसल्स रिलैक्स, जिससे कि इंस्पायरेशन होगा। जैसे ही सांस अंदर खींची, डीआरजी और इंस्पायरेटरी सेंटर जो है वीआरजी के वो इनहिबिट हो गए, मतलब अब ये जस्ट अपोजिट हो गया, और एक्सपायरेटरी सेंटर जो है वो वीआरजी का एक्टिव हो गया, जो पहले इनहिबिट हुआ था ये एक्टिव हो गया। इसका असर फिर इंस्पायरेटरी मसल्स इसके असर से रिलैक्स हो जाएंगे, जबकि एक्सपायरेटरी मसल्स कॉन्ट्रैक्ट हो जाएंगे, जिससे कि एक्टिव एक्सपायरेशन होगा। ऊपर इंस्पायरेशन हुआ था, यहाँ एक्टिव एक्सपायरेशन हो गया। यही पूरी मैकेनिज्म फोर्स्ड ब्रीदिंग कहलाती है। ऊपर का पूरा पार्ट जो 3 बॉक्सेस बने हुए वो इनहेलेशन को दर्शा रहे हैं, और नीचे के जो 3 बॉक्सेस है वो एक्सहेलेशन को दर्शा रहे हैं। और ये 2 अलग अलग कलर्स के अंदर इसको इंडिकेट किया गया है, एक पेल येलो कलर है और एक लाइट ब्लू कलर में ये पूरा मैकेनिज्म बताया गया है, जो बड़ा खूबसूरत सा मैकेनिज्म है। समझिए इसको कि डीआरजी और इंस्पायरेटरी सेंटर वीआरजी का वो एक्टिव हो गया, एक्सपायरेटरी सेंटर इनहिबिट हो गया, जिससे कि इंस्पायरेटरी मसल्स कॉन्ट्रैक्ट, एक्सपायरेटरी मसल रिलैक्स, इंस्पायरेशन करवा देगा ये। फिर अपोजिट डीआरजी और इंस्पायरेटरी सेंटर इनहिबिट, जबकि एक्सपायरेटरी एक्टिव हो गया। जैसे एक्सपायरेटरी एक्टिव हुआ तो एक्सपायरेटरी मसल्स कॉन्ट्रैक्ट हो जाएंगे, इंस्पायरेटरी रिलैक्स हो जाएंगी और एक्टिव एक्सपायरेशन हो जाएगा। सिंपल। अब रिफ्लेक्स कंट्रोल कैसे है रेस्पिरेशन का, तो इसमें इन्फ्लेशन रिफ्लेक्स, डिफ्लेशन रिफ्लेक्स और कीमो रिसेप्टर रिफ्लेक्सेस, 3 रिफ्लेक्स पाए जाते हैं। इन्फ्लेशन रिफ्लेक्स को लंग्स प्रोटेक्ट करते हैं, प्रोटेक्ट्स मतलब ये जो इन्फ्लेशन रिफ्लेक्स है वो लंग्स को प्रोटेक्ट करता है, प्रोटेक्ट्स लंग्स फ्रॉम ओवर एक्सपेंशन। इन्फ्लेशन रिफ्लेक्स लंग को ये कहते हैं कि भाई तू ज़्यादा एक्सपांड मत हो जाना, नहीं तो एक्सपैंड ही रह जाएगा, वापस से नॉर्मल कंडीशन में आ ही नहीं पाएगा। तो ओवर एक्सपेंशन से बचाती है ये इन्फ्लेशन रिफ्लेक्स, जो है वो लंग्स को बचा रही है ओवर एक्सपेंशन से। जबकि डिफ्लेशन रिफ्लेक्स जो है वो जब लंग्स कोलैप्स हो जाते हैं तो उस समय इंस्पायरेशन को स्टिमुलेट करती है। जैसे लंग्स खाली हो गए तो अब इंस्पायरेशन से उसको वापस ऑक्सीजन से भरा जाता है। जबकि कीमो रिसेप्टर रिफ्लेक्सेस जो है वो अगर पीएच में या ऑक्सीजन के पार्शियल प्रेशर में, CO2 के पार्शियल प्रेशर जो ब्लड के अंदर और CSF में उनमें जब चेंजेस आता है तो उसके लिए रिस्पॉन्ड कौन करता है, ये कीमो रिसेप्टर रिफ्लेक्सेस। तो ये 3 तरह के रिफ्लेक्स है जो कि रेस्पिरेशन को कंट्रोल करते हैं। अब हायर सेंटर्स कैसे कंट्रोल करते हैं रेस्पिरेशन को, तो ये पॉन्स पे या रेस्पिरेटरी मोटो न्यूरॉन्स के ऊपर इफ़ेक्ट एग्जर्ट करते हैं, डालते हैं, इफ़ेक्ट डालते हैं। जो हायर सेंटर्स हैं वो पॉन्स पे और रेस्पिरेटरी मोटर न्यूरॉन्स पे अपना असर दिखाते हैं, जिससे वॉल्यूंट्री एक्शन जैसे स्पीच और सिंगिंग के समय, बोलते समय भी आपको भाई आपकी सांस खर्च हो रही होती है, और गाते समय तो आप जानते हैं राग लंबी खींचनी अपन आम लोग खींच ही नहीं पाते, इसके लिए बड़ी वो मेहनत की, वो साधना की ज़रूरत होती है। लोग कितने समय तक प्रैक्टिस कर रहे होते हैं, जो सिंगर्स होते हैं रियाज़ करते हैं सुबह जल्दी उठ करके, इनहेलेशन एक्सहेलेशन वाला ब्रीदिंग को कंट्रोल करने का वो पूरा हमेशा एक्सरसाइज करते हैं। वो क्यों करते हैं, क्योंकि ये इन्हीं को यही चीज़ें कंट्रोल हो रही है ना इससे, इसलिए। इसी तरह से जो इनवॉल्यूंट्री एक्शन है वो लिम्बिक सिस्टम से चलता है, जिसमें रेज, ईटिंग और सेक्सुअल अराउजल हो रहा होता है, तो उस समय भी आपकी सांसों में चेंज आ रहा होता है। सेक्सुअल अराउजल के दौरान भी सांस जो होती है वो तेज़ हो जाती है, खाने के समय भी सांस जो है वो चेंज हो जाएगी, और रेज के दौरान भी ऐसा होता है। अब पॉन्स और मेडुला ऑब्लंगेटा में जो रेस्पिरेटरी सेंटर्स है वो क्या करते हैं, वो ब्रीदिंग का बेसिक पेस सेट करते हैं। जैसे ही एज मॉडिफाइड बाय इनपुट फ्रॉम कीमो रिसेप्टर, बैरो रिसेप्टर्स एंड स्ट्रेच रिसेप्टर्स, जैसे ही इन 3 रिसेप्टर से उनको इनपुट मिलता है वैसे ही वो ब्रीदिंग का बेसिक पेस सेट करते हैं। इसके अलावा CO2 का लेवल जो है वो इस ब्रीदिंग का मेन ड्राइवर है। CO2 का लेवल हमारे ब्रीदिंग का मेन ड्राइवर है, ना कि ऑक्सीजन का लेवल। और प्रोटेक्टिव रिफ्लेक्सेस जो है वो इंटरप्ट करते हैं ब्रीदिंग के अंदर, और कॉन्शियस कंट्रोल करते हैं ये हमारे रेस्पिरेटरी मसल्स को। ये रेस्पिरेशन का कंट्रोल देखिए। हायर सेंटर्स जो सेरेब्रल कॉर्टेक्स, लिम्बिक सिस्टम और हाइपोथैलेमस से बना हुआ है। CSF में कीमो रिसेप्टर्स बताए गए हैं। रेस्पिरेटरी सेंटर्स पॉन्स के अंदर दिखाया गया है। ये सेरेबैलम के अंदर देखिए, 9th 10th ये नर्व्स देखिए। कीमो रिसेप्टर्स और बैरो रिसेप्टर्स कैरोटिड और एओटिक साइनसेस के अंदर दिखाए गए हैं। स्ट्रेच रिसेप्टर्स आपके लंग्स के अंदर है। डोर्सल रेस्पिरेटरी ग्रुप और वेंट्रल रेस्पिरेटरी ग्रुप डीआरजी वीआरजी का जिसका अपन रोल पढ़ रहे थे, रेस्पिरेटरी रिदमिसिटी सेंटर हैं दोनों के दोनों। देख लीजिए इन सेंटर्स को अच्छे से, अभी नाम आए थे इनके। कहाँ पर नाम आए थे इनके? इनके नाम आए थे जब अपन फोर्स्ड ब्रीदिंग पढ़ रहे थे तब। इसके अलावा मोटर न्यूरॉन्स बताए गए हैं जो कि डायफ्राम को कंट्रोल कर रहे हैं। मोटर न्यूरॉन्स जो कि दूसरे रेस्पिरेटरी मसल्स को कंट्रोल कर रहे हैं वो दिखाए गए हैं। तो डायग्राम को देखिए, और यहाँ पर जितने भी लाल एरो हैं वो स्टिम्युलेशन को इंडिकेट कर रहे हैं, जबकि ब्लू एरो जो है वो इनहिबिशन को इंडिकेट कर रहे हैं। अब बर्थ के समय रेस्पिरेटरी क्या चेंजेस दिखाई देते हैं? तो बर्थ से पहले की कंडीशन जिसमें पल्मोनरी आर्टेरियल रेजिस्टेंस हाई होता है, रिब केज जो है वो, ये जो रिब्स का आपका जाल है वो कंप्रेस रहता है, लंग्स कोलैप्स्ड रहते हैं, एयरवे और एल्वियोलाई जो है वो फ्लूइड से भरा हुआ रहता है। बच्चे की बर्थ से पहले उसके पल्मोनरी आर्टेरियल का रेजिस्टेंस बढ़ा हुआ होता है, रिब केज कंप्रेस हुआ, लंग कोलैप्स्ड होता है, एयरवे एल्वियोलाई जो है वो फ्लूइड से भरे रहते हैं। और बर्थ के बाद हेरोइक ब्रीद जो है वो अचानक लंग्स के अंदर बढ़ जाएगी। मतलब जो अभी लंग्स पूरी तरह से खाली थे, में फ्लूइड भरा हुआ था, एयर नहीं थी, वो अचानक एयर से भर गए लंग्स ब्रीदिंग के थ्रू, और फ्लूइड वहाँ से डिस्प्लेस हो जाता है और एल्वियोलाई जो है वो खुल जाते हैं। यहाँ पे सर्फेक्टेंट रिलीज होते हैं जो कि ओपन एल्वियोलाई को स्टेबलाइज करने का काम करते हैं। अब रेस्पिरेटरी सिस्टम की एफिशिएंसी जो लूज़ हो जाती है तो इलास्टिक टिश्यू डिटोरिएट्स हो जाएंगे। अगर वो लूज़ हो गई तो रिब केज मूवमेंट रुक जाएगा और कुछ और एम्फिसीमा जैसी चीज़ें वहाँ पे दिखाई देगी। अब इलास्टिक टिश्यू डिटोरिएट्स हो जाते हैं क्योंकि आप जानते हैं भैया आपके लंग्स के अंदर आपके रेस्पिरेटरी सिस्टम में इलास्टिसिटी पाई जाती है, इसलिए तो कॉन्टैक्ट रिलैक्स हो रहे हैं। तो इससे क्या होता है, जैसे इलास्टिक टिश्यू खराब होंगे, बिगड़ेंगे, तो आपकी वाइटल कैपेसिटी अचानक ही कम हो जाएगी। रिब केज का मूवमेंट भी उस समय रेस्ट्रिक्ट हो जाता है। आर्थराइटिक चेंजेस उसके अंदर आने लग जाएंगे, हड्डियों के चेंजेस आने लग जाते हैं, और कॉस्टल कार्टिलेज जो है उसकी फ्लेक्सिबिलिटी ख़त्म हो जाती है, और कुछ एम्फिसिमा जो है वहाँ पर दिखाई दे रहा होता है।
तो अब आप क्या क्या जान गए हैं? आप लोगों को पता है कि पल्मोनरी लोब्यूल क्या होता है, एसिनस क्या होता है, और रेस्पिरेटरी ट्री क्या है। अब हम थोड़ा सा इसका पैथोलॉजी, हिस्टोपैथोलॉजी जान लेते हैं कि रेस्पिरेटरी ट्रैक्ट इज एक्चुअली लाइंड बाय द सूडो स्ट्रैटिफाइड कॉल्यूमिनर एपिथेलियम। दिस इज कॉल्ड द रेस्पिरेटरी एपिथेलियम, सूडो स्ट्रैटिफाइड कॉल्यूमिनर एपिथेलियम. This is not the ciliated epithelium. Remember, an alveolar sac is lined by two type of cell. Out of them, first is the pneumocytes, membranous pneumocytes, which is actually contains the 95% of the part, and the second type is the granular pneumocytes, which is containing the 5% of the rest of the part. So let's see, this is a bronchial tree, and यहाँ पर एक ciliated epithelium जैसा लगता है, but it is a pseudo stratified columnar epithelium. ये pseudo stratified, जैसे जैसे हम नीचे की तरफ जाते जाते हैं towards the lower respiratory tract or towards the alveoli, we are getting the squamous cell. It is converting into the squamous cell. So the epithelium is very important here, and this lining or these ciliated structures are working like a झाड़ू. Okay, ये जो भी डस्ट पार्टिकल्स हमारे रेस्पिरेटरी सिस्टम में चले जाते हैं इनको आउट करने का काम करते हैं ताकि वहां पे चिपके नहीं और इन्फेक्शन ना हो. ठीक है. सो अपर रेस्पिरेटरी ट्रैक्ट और लोअर रेस्पिरेटरी ट्रैक्ट, ऊपर से नीचे की तरफ जब हम एपिथेलियम की बात करते हैं तो ये जो सीलिएटेड एपिथेलियम है, दिस इज कन्वर्टिंग इन द स्क्वामस एपिथेलियम लोअर द साइड और क्यूबॉइडल एपिथेलियम हियर. सो ये यहाँ पर ये पूरा क्यूबॉइडल एपिथेलियम, नॉट स्क्वामस, क्यूबॉइडल एपिथेलियम. आई एम सॉरी फॉर दैट. सो देयर आर 13 it is a slide number 13. It is taken in from the Robinson. This diagram has been taken, that's why it is a layer of the trachea. In the tracheal lumen, the first layer is a mucosa, then there is a submucosa, then there is a cartilaginous layer, and adventitia is also there. सो एल्वेलर म्यूकोजा की अगर हम बात करें तो 95% of the time in alveolar mucosa it is containing the pneumocytes. These are the flat thin squamous cells which are ideal for gaseous exchange, and they share a basement membrane with the pulmonary capillary endothelium forming the air-blood barrier where the gaseous exchange is taking place. And type 2 pneumocytes are the synthesized cells of the alveolar surfactant. देखिए, हम जब सिस्टिक फाइब्रोसिस की बात करते हैं, कुछ डिजीजेज हैं जहाँ पर सर्फेक्टेंट कम हो जाता है, तो वो जो डिजीजेज एम्फाइसीमा की बात करते हैं, तब उस कंडीशन के अंदर ये सेल्स का बहुत बड़ा रोल है, क्योंकि ये जो टाइप 2 नीमोसाइट्स है, these are the synthesizing cells which are secreting the alveolar surfactant which make it lubricated and flexible, which is very important part, very important property in maintaining the alveolar and airway stability. Lung surfactant can reduce the surface tension and prevent the alveolar collapse and एयरवे वॉल कोलैप्स. अगर सर्फेक्टेंट नहीं होगा तो क्या होगा, एल्वोलाइज जो हैं छोटी छोटी वो कोलैप्स हो जाएंगी, बंद हो जाएंगी. ये इसकी टेंशन मेंटेन करती है सर्फेक्टेंट, है ना. तो दिस इज वेरी इंपॉर्टेंट. यू कैन सी हियर दिस इज अ कैपिलरी. ये जो एल्वोलर सेक है इसके सराउंडिंग के अंदर ये कैपिलरी बेड है. ये कैपिलरी नेटवर्क इस तरीके से बिछा होता है जहाँ पर गैसियस एक्सचेंज का यूनिट होता है. यहाँ पर आप देख रहे हैं ये सर्फेक्टेंट है, जो ब्लू कलर का लाइनिंग आपको नजर आ रहा है, दिस इज अ फ्लूइड विद सर्फेक्टेंट, एंड दीज आर द टाइप 2 सेल व्हिच इज सिक्रेटिंग दिस टाइप ऑफ surfactant or fluid here, which maintains the surface tension of this alveolar sac so that the gaseous exchange has taken place. If the surfactant low become low and it is causing the collapse, alveolar collapse, and there will be no gaseous exchange will take place. And here the gaseous membrane oxygen is taking out, and the carbon dioxide is coming in the alveolar sac. Okay, so by this the oxygenation is happening here, and here is a red. Why it is red? Because oxygen rich blood is there and this is oxygen poor blood, so this capillary is coming from here and going through here. So ये एल्वेलर मैक्रोफेजेस हैं. अंदर की तरफ एल्वेलर सेक का पिक्चर आपको देख सकते हैं. दिस इज द पार्ट एक्चुअली विच इज द रेस्पिरेटरी यूनिट वो in the lung. So this was the pathology. Remember the terminal bronchiole contain the sclera cells. जो टर्मिनल, जब हमने ट्री की बात करी थी तो हमने देखा प्राइमरी, टर्शरी, then secondary and tertiary bronchiole, then there is a terminal bronchiole, after that there is a respiratory bronchiole, and respiratory bronchiole के बाद में आपका एसिनस शुरू हो जाता है. respiratory bronchiole, alveolar sac and alveolar duct compiled called the acinus. This is the respiratory unit. So terminal bronchiole contain the sclera cells. Not only the terminal bronchiole, even respiratory bronchiole is also contain the sclera cell, which is again secreting a surfactant, a component of surfactant, and it has three functions. It is producing one component of surfactant, act as a stem cell, and contain the enzyme system that deoxify the noxious substances. The terminal bronchi contain the maximum smooth muscles सेल रिलेटिव टू द वॉल थिकनेस. यहाँ पर सबसे ज्यादा स्मूथ मसल सेल होती है. ठीक है, हाँ, ये एक पार्ट है जो आपको पता होना चाहिए रेस्पिरेटरी सिस्टम स्टार्ट करने से पहले. दिस इज अ कोलेट्रल एयरवेज. कोलेट्रल एयरवेज क्या होते हैं? कोलेट्रल एयरवेज मींस पोर्स ऑफ कांस इंटर एल्वुलर. तीन तरीके के चैनल्स होते हैं कोलेट्रल एयरवेज, जहां पर इंटर एल्वुलर, एल्वुलाई के बीच के अंदर, एल्वुलाई और इंटर ब्रोंकियोलर, दो ब्रोंकाई के बीच में सेप्टा होते हैं, या ब्रोंको एल्वुलर, इंटर ब्रोंकियोलर मतलब एक ही ब्रोंकियोल्स के बीच में, और ब्रोंकाई और ट्रेकिया के बीच में, यहाँ पर ब्रोंको एल्वुलर, ब्रोंकाई और एल्वुलाई के बीच में, सॉरी. तो दिस इज द ब्रोंको एल्वुलर. तो तीन तरीके के सेप्टास होते हैं, पोर्स होते हैं, जो कि आपस में भी गैसेस एक्सचेंज कर सकते हैं. जैसे पोर्स ऑफ पोहान जो है इंटर एल्वुलर, दो एल्वुलाई के बीच के अंदर ये एल्वुलर वॉल प्रेजेंट होती है विच अलाउ द पैसेज ऑफ द बैक्टीरिया एंड एक्सुडेट बिटवीन द एडजेसेंट एल्वुलाई. क्योंकि आप देखिए, अगर लास्ट यूनिट एल्वुलाई होती, अगर ये कोलेट्रल एयरवेज नहीं होते तो कैसे फैलता इन्फेक्शन? कोई चांसेस ही नहीं थे ना. पूरा वापस ऊपर आएगा देन नीचे जाएगा, तो इट विल बी, इट इज नॉट इजी टू स्प्रेड ना. सो ये जो सेप्टाज हैं वो बहुत ही पैसेज अलाउ करते हैं पैसेज को इजीली एक दूसरे को कनेक्ट करने में। तो दो एल्वेलाइज के बीच के अंदर आपस में एक सेप्टा होता है जिसे पोर्स ऑफ कोहान्स कहते हैं, और चैनल ऑफ मार्टिन कहलाता है दो ब्रोंक्यूल्स के बीच में। जो ब्रोंक्यूल्स होती हैं वो भी आपस में कनेक्टेड होती है, तो दो ब्रोंक्यूल्स के बीच में चैनल ऑफ मार्टिन कहलाती है, और ब्रोंक्यूल और एल्वेलाई के बीच में भी पैसेज बना होता है जिसे हम चैनल ऑफ लैम्बर्ट कहते हैं। So this is very important. It come in your MCQ. So you should remember about this. Now we're talking about the alveolar septa. Alveolar wall and septa are the sites of exchange between the blood and air. ये यहाँ पर आप देख रहे हैं ये एल्वेolar सेप्टा है जहाँ पर गैसियस एक्सचेंज टेकिंग प्लेस होता है, और ये सर्फेक्टेंट है यहाँ पर। दिस इज अ पोर एंड now this is a schemic presentation of alveolar capillary membrane and pulmonary capillary venous end is there. This is again the same diagram which is showing the process here. So you are able to understand by this diagram about the arterial end as well as the venous end. Here oxygen is coming in, and this is a basement membrane inside the alveolar sac, and here is the alveolar capillary membrane is of 4 micron meter. And now next to this slide you can understand this diagram. This is an endothelium. This here is a endothelium membrane inside. The capillary lumen is there, and this is a type 1 pneumocyte. आप देख पा रहे हैं ये टाइप 1, ये एकदम फ्लैट है, ये दिखाई देंगे। ये जो गोले मतलब अगर आप ये एक पर्टिकुलर एल्वेolar सेक का सेक्शन लिया गया है, अगर थोड़ा बड़ा होता है ये डायग्राम तो ये सेकंड एल्वेolar सेक यहाँ पर है, ये फर्स्ट यहाँ पर है, थर्ड यहाँ पर है, फोर्थ इधर है। ये सराउंड कर रहे हैं पूरे नीमोसाइट 1 से। ये नीमोसाइट 1, दिस इज अ फ्लैट, एंड दिस इज अ नीमोसाइट टाइप 2 नीमोसाइट व्हिच इज सिक्रेटिंग द सर्फेक्टेंट हियर. It is an interstitium. This is an interstitial cell, and this is a capillary lumen. This is an endothelium. Endothelial lining है ये यहाँ पर, ठीक है। तो ये आप देख पा रहे हैं कि ये इस तरीके का स्ट्रक्चर है जो आप अंडरस्टैंड कर सकते हैं। This is a normal diagram, the histopathology diagram. Here again you are able to understand this alveolar type 1 cells and type 2 cells are also there, and air space है ये पूरा। ये ल्यूमन ऑफ द ब्लड वेसल्स है। तो इस तरीके का नॉर्मल लंग के अंदर जब हम हिस्टोलॉजी देखते हैं, पैथोलॉजी देखते हैं, तो इस तरीके की दिखाई देती है। देखिए जो हमने इतना बड़ा ट्री जब पढ़ा है अभी, तो ये ट्री क्यों इम्पोर्टेंट है? ये ट्री इसलिए इम्पोर्टेंट है कि एवरी पार्ट हैज इट्स ओन डिजीज। जस्ट I'll tell you, there are many types of respiratory diseases, obstructive, restrictive. तो obstructive disease में हम one by one करके सभी पढ़ेंगे, just like asthma, COPD, emphysema, bronchiectasis, cystic fibrosis, bronchiolitis. The asthma is a disease of obstructive pathology. Chronic bronchitis, emphysema is a disease of acinus. ब्रोंकिएक्टाइसिस ये सब ब्रोंकाई की डिजीज। सिस्टिक फाइब्रोसिस इज अगेन अ डिजीज ऑफ एल्वेolar sac। तो जब तक आपको पार्ट्स नहीं पता होंगे तब तक आप पैथोलॉजी नहीं पढ़ सकते हैं। एंड दिस इज एन पैरेन्काइमा। ये सार्कोइडोसिस, निमोकोनियोसिस, इडियोपैथिक पल्मोनरी फाइब्रोसिस, ड्रग रेडिएशन इंड्यूस्ड इंटरस्टिशियल लंग डिजीज है। These are the parenchymal disease. ये एक्स्ट्रा parenchymal disease है। न्यूरोमस्कुलर डिजीज, यहाँ पे जीबी सिंड्रोम है, डायफ्रेगमेटिक पाल्से है, मस्कुलर डिस्ट्रॉफी, सर्वाइकल स्पाइन इंजरी, ये सब एक्स्ट्रा पैरेन्काइमल है। मतलब लंग की पैरेन्काइमा में प्रॉब्लम नहीं है, कहीं और प्रॉब्लम है, बट इट इज अगेन कॉजिंग द प्रॉब्लम विद द लंग। सो काइकोस्कोलियोसिस, ओबेसिटी, एंकाइलोजिंग स्पॉन्डिलाइटिस, इनके जो आफ्टर इफेक्ट्स हैं वो लंग के ऊपर पड़ते हैं। तो बेसिकली ऑब्स्ट्रक्टिव एंड पैरेन्काइमल डिजीज हमारा मेन मुद्दा है। इसमें भी ऑब्स्ट्रक्टिव डिजीज सबसे ज्यादा इंपॉर्टेंट है। अस्थमा, सीओपीडी, ब्रोंकिया एम्फाइसेमा, bronchiectasis, cystic fibrosis and bronchiolitis. These are the diseases we'll talk in our next lecture about one by one. So I hope till yet you have understand the whole lecture in this platform.
Hi friends, this is Dr. G. Nagendra Babu. I am taking organon perspective in homeomedicine. Today's topic is like organon perspective and organons analysis, especially miasmatic analysis of respiratory system. Organon says, treat the patient, not the disease. Every person, every homeopath should always remember that the treatment in homeopathy is always given to the person. But it is also true that the person, when the vital force suffers, excuse me, when the person suffers, it is actually reflected on his body, right? And the symptoms are the cries of vital force. In the patients with respiratory system, the vital force is crying through the system, respiratory system. And initial stages, the disease is in functional level, any disease as such. So we call it as soric. And when it is not controlled properly, when the pathology advances because of various reasons, the disease progresses and the sora starts accepting psychosis and syphilis. That is how the mixed miasmatic disease comes in. Then the disease becomes usually difficult to cure, not incurable. So that is the first point. So when it comes to miasmatic analysis of respiratory tract, we should remember that the treatment is given to the patient, but the reflected disease also has to be cured, which is right now showing in the respiratory tract. Richard Hughes always says the individualization can be done in 3 levels. One is tissue level, second one is systemic level, third one is constitutional level. So probably today we are dealing with respiratory tract, the systemic level, right? Usually the respiratory tract consisting of, we call it as upper respiratory and lower respiratory. In our practice also generally we come across upper respiratory diseases and lower respiratory diseases. To make it simple for UG students, the sinusitis, the allergic rhinitis, the common cold, okay, all these things can be taken as upper respiratory problem. Whereas emphysema, bronchial asthma, bronchiectasis or tuberculosis, everything can be kept under lower respiratory or entire respiratory tract. Now, how to do the miasmatic analysis, whether the patient is soric or syphilis or psychotic? Now we are entering into the main topic. When it comes to upper respiratory tract, the principle runs the same. Remember, homeopathy is very simple. Only thing is we complicate it. How it is simple? Sora always develops functional disturbances where the structural damage is not happening. Psychosis is a proliferative growth where you have extra growths. Remember this basic point. And psychotic discharges are yellowish and greenish in nature. When it advances and joins with syphilis, syphilis causes destruction, right? So nasal bone is disrupted, zygomatic bone is disrupted. The sinusitis mucous membranes are broken, reddish, and bloody discharges are coming. Such things comes under a syphilitic perspective. When the sora combines with syphilis, usually it is not Heinemannian concept, Allen's concept, J.H. Allen's concept. He contributed another miasm, tubercular miasm. Please remember, tubercular miasm is not Heinemannian concept. It is J.H. Allen's concept in his book Chronic Miasm. So when sora joins hereditarily with syphilis conjointly, then we call it as tubercular miasm we are talking about. Tubercular miasm will have both soric and syphilitic concepts. To make it very precise, in soric concepts, the patient is highly sensitive because remember, sora is also called as sensitizing miasm. So patient is highly sensitive to all external impressions like smell, dust and everything. Usually you see in allergic disorders, right? Even the cooking food nauseates. We have seen so many medica remedies. I am not going deep into that. Okay, he has any allergy or hypersensitivity or sensitiveness to smell, even the food, perfumes, the paint. Okay, it causes headache, severe headache, even sometimes fainting by the smell of the food or any other hot smell. Cold begins with sneezing. Thin, watery discharge, which is acrid in nature. We have seen acute cases in medica. Thin, acrid discharge reminds you some remedies, right? Sensitive boils, dry, burning sensation in the nose. Okay, associated with rhinitis, but anosmia is not that much marked in SORA. Okay, vesicles may be formed which are reversible in nature. They are filled with water. The vesicles are filled with watery discharge. Epistaxis may be there, but it is very rare and scanty. Remember, epistaxis is generally comes with tubercular miasm. SORA and syphilis when joined, you have epistaxis predominant. Then tubercular miasm will come. Vesicles and pimples can be present on the septum. The painful septum will be there when you examine through the torchlight. With the help of torchlight, we can see the vesicles on the septum. That is soric. Always remember, any disease which is pathologically not advanced, then you can put under soric, which is reversible in it. Simply we can say common cold, which is reversible, is soric in nature predominantly. You should not think like that. Then comes your syphilis. What is that? Loss of smell, complete loss of smell. Remember COVID? COVID is also a form of influenza virus, but it is so virulent in nature that it caused severe anosmia and it caused severe pain, okay, which is very, very dangerous and fatal. Such thing can be generally mixed miasmatic, but predominantly syphilitic in nature. So snuffles in children with bloody discharge. Bloody discharge on sneezing can be kept under syphilitic miasm. Bones are generally destroyed. Remember, syphilitic miasm, the favorite spot of syphilitic miasm is blood and bones. We have studied that. So here blood predominates and bones of the face, which are very uncommon and rare in nature, right? You know, in pathology, easily the facial bone does not decay. But here, in syphilitic miasm, which is destructive in nature, the bones are destroyed enormously. Even you can see the deep fissures inside. Moles and papillomas are also developed, which are syphilitic in nature. Along with the soric symptoms, you can see these extra added symptoms in syphilitic miasm. Proceeding to psychotic, anosmia, the loss of smell, snuffles with thick discharge in the nose, severe nasal block, the discharge is smelling very badly. Remember that hearing brain? That smell, bad smell, you will notice in a psychotic miasm, and the discharge is predominantly yellowish or greenish in nature. Remember, it reminds you of gonorrheal discharge, which is coming all over systemically. Acrid green, yellow color discharge you will notice in psychotic miasm. Polypy of the nose, nasal polyps, which causes the obstruction, which recommends surgeries. Those fall under psychotic miasm. Children frequently suffer with acute coryza, copious discharges, especially watery can be there, but especially thick yellowish discharges with snuffles in children, which is very severe in nose. And here we have to notice one thing: soric symptoms aggravate in the evening hours and early morning hours. A psychotic usually aggravates in winter season, and the syphilis always aggravates in the night time. Nighttime modality is one of the characteristics of syphilitic miasm. Now proceeding to tubercular miasmatic background, hemorrhages is predominant because the combination of SORA and syphilis comes here. The hemorrhage and epistaxis from nose predominates in tubercular miasm. Bright red discharge will be there, which is profuse in nature. It's not simple like SORA. The bleeding is very profuse from the nose. Okay, the slightest exertion, slightest blowing of the nose also causes severe bleeding. Severe vertigo associated with common cold is noticed in tubercular miasm. Foul smelling discharges, postnasal dripping, severe postnasal dripping, acne kind of growth on the nose, catarrhal thick discharges, yellowish discharges, which is smelling like old cheese or hydrogen sulfide. You can see hydrogen sulfide is very bad smelling gas. That discharge is predominantly noticed in nasal discharge of tubercular miasm. Now, once the upper respiratory tract is over, you are getting into lower respiratory tract. How do you assess whether it is storic or psychotic and syphilitic or tubercular? The same you have to remember. The functional disturbances comes under SORA. Please by heart it. Syphilitic comes destructive. Psychotic is proliferative growth and blockages, growths, big growth. And tuberculosis, the combination of SORA and syphilis will come, but predominance of bloody discharges will be there. Now coming to SORA, structural discharges are very less in SORA. Usually you should not consider them. Dry spasmodic cough in asthmatic patients and bronchitis patients and emphysema patients. Emphysema is generally a combination of mixed miasm, but every disease starts as a soric manifestation. I told you, when it is not controlled, it progresses to mixed miasm. SORA itself does not cause any structural changes, only mixed miasm produces frequent dyspnea. Hydrothorax in mild nature can be considered as soric manifestation. Now coming to psychosis in lower respiratory tract, the lungs, the bronchiole, bronchial tree and all these things. Cough with one or two distinct barking like dog is noticed in syphilitic miasm. Hoarseness before periods in females. Dyspnea aggravates when lying down in the bed flat, especially in the night time. Thread-like mucus with barking cough, dog-like barking cough predominates in syphilis. Now psychosis, very little expectoration, but as usual, yellowish, greenish discharge from the respiratory tract, especially lower respiratory tract. The cough is usually coming from the bronchus, the bronchiole. Bronchus, the cough is coming. Bronchitis is generally psychotic in nature, bronchitis. Bronchiectasis can be kept under either syphilitic or tubercular because the bloody oozing predominates there and severe destruction of bronchial mucosa will be noticed in those cases in bronchiectasis. Asthma, bronchitis, pneumonia aggravates in humid, moist weather in psychotic. You know, when it rains, it pains. When it rains, it pains. That means when it is raining, the watery environment, aggravation by watery areas is psychotic in nature. So all these lower respiratory tract problems will aggravate in rainy season, moist areas by lying down on the abdomen, which is ameliorating in psychosis, lying down on the abdomen. You remember one medica remedy, lying down aggravates, keeping the tongue outside. Dyspnea ameliorates by passing the stool. Passing the stool temporarily ameliorates the psychotic miasm. Please note this point. Cough is usually noticed in bronchial area. That is in psychosis. So here it's more of the proliferation. The bronchial lumen will get enlarged because it swells up, right? Psychotic, it is more proliferation. And when it swells up, the air does not enter inside, the patient suffocates. Dyspnea is because of that pathology in psychotic miasm. Proceeding to tubercular miasm, there is a history of tuberculosis because related to lung. Then you have to consider tubercular miasm. The imperfect or lack of good morphology of the chest is considered as tubercular miasm, especially the narrow chest, pigeon chest, funnel chest, sunken chest, kernel chest. Because of chronic respiratory problem and defective bones, okay, the chest is actually, the chest shape is actually deformed in tubercular miasmatic cases. Complaints from least exposure to cold, okay, cough with purulent expectoration, the yellowish and sweetish expectoration, saltish expectoration. Remember the phosphorus which is considered as a strong tubercular miasmatic remedy with narrow chest, is having a sweetish, saltish expectoration. Tuberculosis predominant, that is a tubercular miasmatic background is there in phosphorus. And phosphoric acid is also there, and stannum metallicum is also there, which predominates in sweetish and yellowish, sweetish and saltish expectoration, which shows tubercular miasm. And one more thing, the swelling of the cervical gland. Okay, those things, wherever it is, the swelling of the cervical gland or lymph nodes, swelling of lymph nodes comes under tubercular miasm. Usually predominates in tubercular miasm. What are the modalities here? Already we have discussed when I explained the symptoms. The psoric complaints are usually aggravated by standing, heat, pneumonia, after eating, approach of the menses, sunrise to sunset, okay, by touch or strong smelling odors. It is ameliorated. The psoric symptoms are ameliorated by walking, lying down, being quiet, and slow movement will ameliorate. Slow movement will ameliorate there. Skin diseases reappearance when psoric respiratory complaints ameliorate. When the respiratory complaints of psora ameliorates, the skin diseases will reappear. This is one of the sign modality of improvement in psoric respiratory diseases. Coming to syphilitic miasmatic miasms, other modalities, complaints are aggravated by night, warmth, sweat, rest and exertion. All pathological discharges, that means the phlegm or bloody discharge, hematemesis, hemoptysis, usually ameliorates syphilitic respiratory complaints temporarily. Because one more point you please remember, physiological discharges ameliorate psora, pathological discharges ameliorates in psychosis and syphilis. Syphilis patient is better by cold in daytime because night aggravates. Pus discharge ameliorates him. Leukorrhea and otorrhea ameliorates him. Like just now I said, pathological discharges ameliorates syphilis. Psychotic complaints are aggravated by rest. Psychotic complaints are aggravated by rest. Rainy season aggravated by cold, usually 4 to 6 a.m. when the weather is chilled, it's ameliorates. Psychotic patient is compared to a barometer by Phyllis Pite. You should read Phyllis Pite book for understanding miasmatic symptoms of all miasms. And psychotic complaints are ameliorated by slow movement, like your psora and psora. Lying on abdomen ameliorates the patient's complaints. Dry weather ameliorates psychotic complaints. Pathological discharges like leukorrhea, otorrhea ameliorates psychotic patient. Tubercular patient is aggravated in the night because syphilis predominates their destruction. Aggravation by thunderstorm. Any pressure on chest will aggravate. Talking, laughing, shouting. Too much of usage of chest also aggravates the tubercular miasmatic complaints. Amelioration of tubercular complaints is nose bleeding. Epistaxis ameliorates in tubercular miasmatic complaints. Dry weather and open air also ameliorates. So, to a nutshell, what I summarize is, just like any other drug picture in Medica, you should always remember and recall the symptoms of miasm. Any miasm, psora, syphilis and psychosis. Phyllis Pite has given a beautiful explanation of these miasms. In fact, she is the first who identified miasmatic symptoms generally. Because Master Heinemann did not give any separate books or literature on miasmatic symptoms. So we have to understand that. And my book on comprehensive study of organon is also there. I have given a separate annexure for understanding miasm. So you can go through that. And thank you HomeoED for this opportunity. Thank you very much.
Good afternoon. Myself, Dr. Yogita Kumari. Today, I'll be taking respiratory diseases in your practice of medicine. So, let us start with it. So, we all are well versed with the actual structure, the anatomy of the respiratory system, and the functions the respiratory system is doing for the body, for the human body. And we all know the functions of various structures in the system. So let us start. So respiratory system, what respiratory diseases are. So respiratory diseases are the illnesses that affect the organs and tissues in the lungs and airway systems, making gases exchange and breathing difficult. सो जब भी हम पढ़ रहे हैं रेस्पिरेटरी सिस्टम के बारे में, तो फर्स्ट वी शुड बी वेरी वेरी क्लियर कि क्या तो वो सिस्टम है, क्या उसका फंक्शन होता है, और वो फंक्शन जो है वो इम्पेयर हो रहा है, उसी से हम लोगों को डिफ़िकल्टी महसूस होती है, और वो डिफ़िकल्टी कैसे कैसे महसूस होगी. तो व्हाट इज़ द बेसिक स्ट्रक्चर एज यू कैन ऑल सी ऑन द स्क्रीन, द ट्रेकिया, लंग, और ये पूरा का पूरा सिस्टम जो हमको दिख रहा है. आगे भी इसके बारे में डिटेल में हम लोग पढ़ेंगे. बट देन द फंक्शन दे आर डूइंग इज द गैशियस एक्सचेंज. और यहाँ पे मेजर हमारे को किस किस चीज़ों की प्रॉब्लम आएगी. ब्रीदिंग के लिए हमारे जो लंग्स जो हैं, एक्सचेंज ऑफ गैसेस के लिए दे प्ले द मेजॉरिटी रोल. एंड इफ दैट इज नॉट हैपनिंग, द सिम्टम्स व्हिच अराइजेस इज डिफिकल्टी इन breathing and shortness of breath and various symptoms that we're going to learn ahead. Yeah. So first of all, the functions जो भी परफॉर्म करता है लंग्स, इफ दे आर impaired, जो भी हमारे कार्डिनल सिम्टम्स आएंगे. सी whenever we are studying practice of medicines, for all the systems we have some cardinal functions and cardinal symptoms. If all the functions are impaired, this particular system will give a group of symptoms which are very very much linked with the system's dysfunction. सो अगर हमारे लंग्स में कोई भी डिस्फंक्शन हो रहा है, तो वहाँ पे क्या सिम्टम आएंगे हमारे पास. दी कोर सिम्टम्स विच विल कम, जो बहुत ही ज़्यादा डिजीज स्पेसिफिक है वो अलग आते हैं, बट दिस इज दी कोर सिम्टम्स विच विल बी रिफ्लेक्टेड इन दी बॉडी. फर्स्ट एंड फॉरमोस्ट इज breathlessness or dyspnea. The second symptom is cough. The third being sputum or expectoration. The fourth being there are different lung sounds which can happen due to various functional disturbances in the lungs. So wheeze or lung sounds which come out of the lungs on auscultation is one of the cardinal principles and cardinal symptom. And the next is hemoptysis. And the last being chest pain, or basically chest pain cardiology में भी आता है, but thoracic pain या पूरे के पूरे चेस्ट में जो पेन आएगा, नॉट कोर solely belonging to the mediastinal region, it will be thoracic pain basically. So respiratory system diseases are basically divided into two basic parts, which is the upper respiratory diseases and the lower respiratory diseases. So what happens, the upper respiratory system is divided at the level of larynx from the lower respiratory tract. अभी देखें जो भी जो अपर रेस्पिरेटरी, एज द नेम सजेस्ट, अपर रेस्पिरेटरी ट्रैक्ट मतलब जहाँ से हम लोग रेस्पिरेशन मतलब एक्सचेंज ऑफ गैसेस, सांस लेने की जो प्रक्रिया होती है हमारे शरीर में, वहाँ पे शुरुआत कहाँ से होती है, नाक से. तो हम लोग और अंत कहाँ पे होती है, जहाँ पे एक्सचेंज ऑफ गैसेस हो चुका है. कहाँ पे होता है ये, एट द लेवल ऑफ एल्वियोलाई, द एक्सचेंज, the membrane of alveoli where the gaseous exchange is happening. So what is happening is कि upper respiratory tract and lower respiratory tract are divided into two at the level of larynx. So upper respiratory tract में क्या क्या आता है, the nasal cavity, pharynx and the लैरिंग्स, उसके बाद में लोअर रेस्पिरेटरी ट्रैक्ट एंड विच इज डिवाइडेड एट द लेवल बाय द फ्रॉम द अपर रेस्पिरेटरी ट्रैक्ट एट द लेवल ऑफ लैरिंग्स इनटू trachea, primary bronchi or bronchioles, and or the lung or the alveoli. Now the common upper respiratory tract infection. See, I've tried to make it as penetrable as possible into your minds कि upper respiratory tract जब हम पढ़ते हैं कि ऊपर ऊपर कुछ चीज हो रही है या ऊपर ऊपर के स्तर पे हो रही है तो इट इज नॉट दैट क्रिटिकल. तो जो हमें रेस्पिरेटरी ट्रैक्ट इन्फेक्शंस, अपर रेस्पिरेटरी ट्रैक्ट इन्फेक्शंस हम लोग आमतौर पे ओपीडीज में देखते हैं, हम लोगों को भी, हम आसपास के लोगों को बड़े आराम से इन सब तकलीफों से जूझते हुए देखते हैं, विच आर कॉमन कोल्ड. एज यू ऑल नो, दिस पर्सन हु इज टेरिबली ट्रबल्ड बाय कॉमन कोल्ड, यू कैन सी running nose, cough. The next being sinusitis. The picture is very well trying to depict कि साइनोसाइटिस मतलब साइनसेस जो होते हैं उनका इन्फ्लेमेशन हमारे जब हो जाता है, और इसका एक मेन सिम्टम होता है हेडेक, बहुत ही ज़्यादा हेडेक, और ये पिक्चर में भी डिपिक्ट हो रहा है यहाँ से. थर्ड भी टॉन्सिलाइटिस, जो टॉन्सिल्स हैं हमारे एट द लेवल ऑफ फैरिंग्स, टॉन्सिल्स हैं, अगर उनमें स्वेलिंग हो गई है बिकॉज ऑफ रिकरेंट कफ एंड कोल्ड तो यहाँ पे टॉन्सिलाइटिस हो जाता है, इन्फ्लेमेशन ऑफ द टॉन्सिल्स. लैरिंजाइटिस, लैरिंजाइटिस इज इन्फ्लेमेशन ऑफ द लैरिंग्स, बहुत ज़्यादा बोलते हैं, बहुत ज़्यादा ज़ोर से बोलते हैं, बहुत काफ़ी बार बार उन लोगों को स्वेलिंग होती है because of overuse or because of infections. Now coming to the lower respiratory tract. अब lower respiratory tract, हमने upper respiratory पढ़ लिया है, अभी हम लोग lower respiratory tract जब पढ़ेंगे तो you can see कि this is what constitutes the lower respiratory tract. Larynx इसमें नहीं आता, रेड में मार्क किया हुआ है यहाँ पे, larynx is not a part of lower respiratory tract. तो क्या क्या आएगा? larynx के बाद में trachea आता है, तो trachea is in the lower respiratory tract. वहाँ से ट्रेकिया जो है वो जाके दो ब्रोंकाई में डिवाइड होता है, लेफ्ट एंड राइट. सो राइट प्राइमरी ब्रोंकाई एंड लेफ्ट प्राइमरी ब्रोंकाई. उसके बाद में ब्रोंकियोल्स, देन एल्वियोलाई, और पूरा का पूरा स्ट्रक्चर, वो जिस भी चीज़ को सराउंड किया हुआ है, जिस भी चीज़ ने सराउंड किया हुआ है इन सारे स्ट्रक्चर्स को, इंक्लूडिंग द डायफ्राम, द प्रॉक्सिमल पार्ट टू द लंग्स ऑफ द डायफ्राम, दैट इज ऑल्सो इंक्लूडेड हियर. So now this diagram, I've tried to make it as simple as possible. Funnel, I could not turn it down. So what is happening, like it is a capped element in the sense कि अगर हम देखें कि लंग जो है हमारे पास एक्सटर्नल स्ट्रक्चर जो दिखाई देता है, उन स्ट्रक्चर्स में जो प्रॉब्लम्स आएंगे उनके वजह से जो नाम होंगे डिजीजेस के, ब्रॉडली क्लासिफाइड इनटू थ्री, दैट इज ब्रोंकाइटिस, ब्रोंकियोलाइटिस एंड एम्फाइसेमा. अगर ये उल्टा होता तो शायद ज़्यादा बेहतर समझ में आता, बट स्टिल इट इज़ वेरी वेरी अंडरस्टैंडेबल. तो क्या होगा, अगर कोई भी चीज़ ब्रोंकाई में हो रही है, इफ इट इज कॉजिंग एनी प्रॉब्लम देयर, तो ब्रोंकाइटिस होगा. देखें, ट्रेकिया के बाद, इफ यू कैन सी इट फ्रॉम हियर, ट्रेकिया के बाद में प्राइमरी ब्रोंकाई में डिवाइड हो रहा है, उसके बाद में ब्रोंकियोल्स में डिवाइड हो रहा है, एंड द लास्ट इट इज एंडिंग इनटू एल्वियोलाई और एल्वियोलर सैक. तो यहाँ पे क्या होगा कि लोअर रेस्पिरेटरी सिस्टम में पहले दो में डिवाइड होगा, विच इज ब्रोंकाइटिस होगा. अगर ब्रोंकाई में कुछ भी प्रॉब्लम हो रही है तो ब्रोंकाइटिस होगा. अगर ब्रोंकियोल्स में कोई प्रॉब्लम हो रही है तो ब्रोंकियोलाइटिस होगा. और अगर एल्वियोलाई में जाके वहाँ पे इन्फ्लेमेशन आ रहा है तो वो एम्फाइसेमा होगा. Now, common lower respiratory tract infections or diseases are COPD, asthma, interstitial lung diseases, pulmonary fibrosis, bronchiectasis, chronic bronchitis, asbestosis, pleurisy, tuberculosis. Now,
hello everyone. Dr. Soni here. So today we are here to discuss something about respiratory ailments. You know, this is a festive season. Everyone is celebrating this season. This month is full of festival, but also this month is full of respiratory ailment. Respiratory ailment, they aggravate so much in this season. That is because of so much allergens in our environment and weather change. And also in festive season, we take so many sweets and outside food, which also causes so much problem. So we are going to discuss few medicine, homeopathic medicine, which will help in these giving relief in these respiratory ailments. So let's discuss about this medicine. So first, our medicine is arsenic album. You heard so many times about this medicine, and this medicine is a gem, the gem in homeopathy for respiratory ailment. So what happened in arsenic album? See, when there's an exposure of allergens, एकदम से क्या होता है? There's exposure of allergens, and patient they get so much prostrated. They get so much prostrated. They have burning thirst, and it's the most important is its aggravation time. We have midday aggravation, midnight aggravation. Now, patient is suffering from cold, so much sneezing, constant sneezing, violent sneezing. There's no relief in sneezing, and there is a fluent discharge, and patient is so much prostrated, feeling so much weak, lying down, and most of its complaints are aggravated during midday, around 12 to 2 or midnight 12 to 2. This is the key point aggravation you found in arsenic album. And thirst is a burning thirst. Patient is so much thirsty, but what kind of thirst it is? The thirst is for small water. Patient takes sips of water, then get relief. Then again takes sips of water, and especially patient relieves from the warm water. Patient desire warm water, right? Patient is also having so much irritability. Patient is very restless. You will see in arsenic, the patient is very restless. Patient is mentally restless, physically restless. Patient cannot stay at one place, but patient is so weak to move. Mentally, patient is very restless. He is always irritable, very restless, and patient has so much fear. He has so much fear that something will happen to him. So this is what we get in arsenic. This is the keynote of arsenic, that the midnight aggravation, midday aggravation, and so much mentally restless. Patient has burning thirst, right? And burning thirst, which is relieved by taking warm water, right? Patient has so much heat also. Patient feels so much heat in his body, and that heat is also relieved by applying hot water or taking bath in hot water. So this is what we get in arsenic, and arsenic is very mentally restless, physically restless, right? Now, second medicine which we can give in during the season for allergic rhinitis or any respiratory allergy is aconite. When we see the patient, patient has exposure and the attack, it comes so suddenly and violent. When we get attack sudden and violent, मतलब एकदम से पेशेंट को क्या हुआ, एकदम से कोल्ड शुरू हो गया, बहुत सडन, बहुत वायलेंट कोल्ड शुरू हो गया, पेशेंट छींके मारा जा रहा है, पेशेंट को हेडेक भी साथ में है, एंड पेशेंट इज नाउ डल, पेशेंट इज वेरी डल, पेशेंट इज फीलिंग वेरी कोल्ड, पेशेंट इज फीलिंग वेरी चिली, and you can see the patient is very restless, very tensive, so much of fear on his face, so much anxiety on his face, and patient has thirst for cold water. Patient needs cold water at long intervals, a huge quantity of water. So patient feels very much chilly here, right? Patient is dull, patient is so much fearful, and so much anxiety. उसके face में दिखेगा इतनी ज़्यादा anxiety उसको होगी. When this condition go extreme, patient also has fear of death. So aconite is for the first stage. Whenever there is exposure, in the first stage, aconite is a medicine which will give relief to the patient. Now, third medicine we can think of is nux vomica. In this season, what happened? The patient, they take so much food, so much sweets, and they do take so many, outside food, overeating करली, कुछ भी खा लिया उठा के, and now the patient has gastric problem, right? Patient gets gastric problem. He's starting having gastralgia, stomach problem, and also fluent coryza. जब गैस्ट्रिक प्रॉब्लम के साथ फ्लूएंट कोराइजा है पेशेंट को, एंड स्पेशली आफ्टर एक्सपोजर, आफ्टर ईटिंग outside food, and there's some error in the diet, overeating, so then we can think of nux vomica. Patient is always having a sensation of vomiting. He feels that he wants to vomit. This is the keynote. He feels he wants to vomit, and he thinks the vomiting will give him relief, right? So whenever there is error in diet, overeating, right, and patient is having gastric problem, and also then patient having fluent coryza. Also, the patient is very, very irritable. Nux vomica patient, they are never at calm. They are very, very irritable. You go to them, you talk to them, they get irritated. They get irritated at trifles, right? छोटी छोटी बातों में irritate होना. उनके पास जाओगे, उनको console करोगे, then also they can irritate. You go and talk to them, you go and ask something, they will not give you the answer properly, right? So this thing you get in nux vomica. Especially the nux vomica when we are giving, whenever the problem is because of overeating, error in diet, eating so much sweets and outside food, now they are having a gastric problem and so much irritability, restlessness in nux vomica, and patient feels so much chilly and also patient is very thirsty. Now we can think of jacemia. एकदम से क्या हुआ, patient has exposure, right? Exposure to allergens, exposure to cold. Now the patient is very, very dull. Patient is very dull. He cannot stand. He's lying on his bed. He's very dull, drowsy. उसकी eye से दिखेगा कि patient is very, very drowsy. He's so much drowsy. Even उसकी eyelids इतनी heavy होंगी. He cannot move his eyelids. His eyelids is very heavy. He always says there's so much heaviness in his forehead, so much heaviness in his eyelids, right? And patient is very, very dull. He will lie in the bed. He don't want to get disturbed. He feels when he feels better when he lie on his bed. Whenever you go to him, then he doesn't want anyone near him. Patient is thirsty. He doesn't want water also, right? And patient feels very, very chilly, especially chilly in the back. He feels chilliness in the back. So Jacenium patient, the dullness is there, drowsiness is there, dizziness is there, right? Patient is very chilly, chilliness especially where? In the back. And patient is thirstless. Patient doesn't want to get disturbed. He has aversion to disturbance, right? So this we get in Jacenium. And what else? Brainia. Brainia is also very good medicine. Brainia little, onset is not so sudden. Onset it is insidious. He get exposure and after a few days the problem comes. What happened in Brainia? Brainia, especially you see, the Brainia has a gastric problem with the respiratory problem. Brainia patient is also very dull. He also becomes so much dull when he has problem. Also, he has constipation. Whenever there is a respiratory problem with the constipation state, we can think of Brainia. And the onset is insidious. Brainia patient is very dull. He also want to stay at bed because little motion, slight motion also aggravate his problem, right? मतलब even जरा सा भी move करेगा, his problem will aggravate. He needs complete rest. He doesn't want to move at all. Even bed के ऊपर भी he doesn't want to, वो करवट भी लेना नहीं चाहेगा. So he has so much aggravation with the motion and he needs absolute rest. Not only physical rest, mental rest also. He doesn't want to think also. He just lie on bed, lie on a bed, doesn't want to move mentally also, physically also. And whenever you see the tongue is coated. Then you find tongue is yellow coated. And patient has constipation. Patient is also very thirsty. Patient need a lot of water, a large amount of water. Whenever the patient says, I need water, he wants cold water. And he wants a glass full of water. Like arsenic, he takes a sip of water, right? With Brainia, he wants a full glass of water, but at long intervals. So what kind of patient we are dealing with? A patient is dull, patient is drowsy. The main thing is aggravation. Aggravation with the slightest movement. Aggravation with the slightest exertion. And patient wants absolute rest. Right? So arsenic is a very good medicine to deal with it when there is irritability, when there is mentally physical restlessness, when there is thirsty, right? Then also the patient is so much weak, so much burning pains all over the body with chilliness. When the onset is sudden, onset is violent, patient is chilly, and patient is having so much fear and anxiety, we can think of aconite, right? We can think of nux vomica when the problem is because of error in diet, overeating, fluent coryza, right? So much chilliness and so much irritability. See, mental symptoms are very important to observe. In the acute state also, these mental symptoms help to differentiate between the medicines, right? Brainia, when the patient gets constipation along with the respiratory ailment, patient has aggravation with the motion, amelioration with the rest, and patient is very thirsty, patient has tongue coated, white coated tongue, right? What else we can think of? Now when we get coryza, in the case of coryza, we can think of first medicine we think of is allium cepa. Allium cepa में coryza कैसे, बिल्कुल like an onion. Patient has so much acrid nasal discharge, so much acrid nasal discharge, and what happens in coryza, patient has acrid nasal discharge, but whatever comes from the eyes, that is bland. So this is very important in CEPA when the patient is having coryza and the nasal discharge is very very acrid. We can think of ileum CEPA, and its opposite in reverse in euphrasia, when we get bland nasal discharge and acrid ear discharge, acrid tears. So this also helps in relieving the symptoms of coryza during this season. What else we can think of? Pulsatilla. Pulsatilla also is a medicine which is used very much in this season, right? Pulsatilla, when we know that patient is, they had some fried food, fatty food, starchy food, and after that now the patient is having the respiratory ailment. They also having a gastric ailment, and especially the nasal discharge is bland, thick, yellowish discharge. When the patient gets thick, yellowish, bland discharge, patient is dull, patient is thirstless. Now, and especially ailment after eating ice creams, fatty food, fried food. Patient also desire the same thing. This happens in pulsatilla. Patient desire the same thing which aggravates its problem, right? So pulsatilla we can think of whenever the ailment is from fried food, fatty food, ice cream, eating ice cream, and also the patient is having nasal discharge, which is thick, bland, yellowish color discharge. And also the patient is thirstless. Patient feels so much chilliness. In a chronic state, pulsatilla is a hot. It summers is hot. But in acute state, pulsatilla is chilly. She feels so much chilliness along with all the complaints, right? And especially aggravation is in evening. And when we go to the mental state, the patient is having so much emotion. Patient become tearful, patient become emotional, and patient craves consolation. It happens in pulsatilla. When the patient wants, the people come and ask them, what happened to you? What is wrong with you? They crave consolation. That is a natural tendency we find in pulsatilla. So there are so many, as we know, there's so many homeopathic medicine to deal with the respiratory ailment, allergic ailment. But I have told you so a little frame of homeopathic medicine which can help in combating allergies. So thank you so much for this.
Today's our topic of discussion is role of repertories in respiratory infections. We all know that in homeopathy we say that we don't have to prescribe on the disease pathology, and that is very true. But when a patient comes up with certain pathology, he presents with certain signs and symptoms, and these signs and symptoms are our basis of prescription, because every individual has something different or something individualizing which we pick up as uncommon symptom, and we prescribe upon them. Patient with respiratory infections present with many symptoms which are common and uncommon, so we have to pick out or choose the uncommon ones and then prescribe with the basis of the repertory. So when we know what all repertory has in store for us in these respiratory infections, then only can we frame our questions in the case study. I'll give you a little example like cough. Cough is a sign, a symptom that patient presents to us. He comes and says, I have cough. But when we look up in the repertory, we have a whole chapter on the cough, right? And that cough can be of many times, paroxysmal, constant, with pain, without pain, where the pain is occurring, what are the desired aversion during the cough, what are the modalities during the cough, is it productive or unproductive, if it is productive, what are the expectoration like? So many questions. We'll just take a look on what all homeopathic repertory has in store for us. So first, take a quick look on what are the respiratory infections that we can deal with. So respiratory infections, both acute and chronic, and these are the droplet infections. Droplet infections, these can be spread from one person to the other because of the sneeze, the cough, the small droplets can cause infection in the other person. But even if one person catches this infection and the other person carries from him, both will present with a different clinical pictures. And there are various respiratory infections like cough, tonsillitis, ceases, laryngitis, pneumonia, rhinitis, influenza, asthma, emphysema. Some I have missed maybe. So all these infections have to be treated with the help of repertory. We know the common symptoms of these all these diseases I've named here. We know tonsillitis means enlargement of the tonsil, and it has a presenting symptom of cough with it. And then we know thesis is the other name for tuberculosis. There also there is cough. Then laryngitis, it also has cough. Pneumonia, again cough with chest involvement. Rhinitis with cold. Influenza, more of cold, less of the cough symptoms will be there. Chest involvement. Asthma is difficult breathing. Then cough, there are variety of cough as I told you. So we have to deal with all these diseases, but how we deal with it? We deal with it with the help of the presenting signs and symptoms. We just go by the presenting signs and symptoms and we repertorize the case. I'll give you an example of this repertorization. See, cough, you can see the screen, cough, eating after, cough, lying aggravation, cough, talking aggravation, cough, constant. So the patient presented with the complaint that I have this constant cough, which is aggravated every time I talk. It is aggravated when I lie down, more at night, whenever I eat something. So this these all symptoms are very important, very important, because we have to deal with all these symptoms when we have to deal with our patient. So I'll just show you how. See, our repertory has all the chapters listed here. Cough, total chapter on cough, a total chapter on expectoration, a total chapter on respiration. We'll see here. See, respiration. So I've opened this chapter on the chest, then a chapter on chest here. On the chapter, in the chapter chest, if we just go and type lungs, so what we have all the symptoms or all the remedies listed pertaining to the lungs. Which lung is affected? Left, right. Which part of the lung is affected? Apex, middle, or the base, right? Then we'll open out the cough chapter. So what we have to do here in repertory, we have to study all these signs and symptoms. At least once we have to go through all the symptoms which are there in our materia medica, as well all the rubrics which are there in the repertory, and be well versed, so that then only when the patient comes to us, we will be able to ask him the questions, and on the basis of those questions we'll be able to come to a single remedy. There are so many remedies. If we say dry cough, there are so many remedies. If we say cough with expectoration, again we have so many remedies, but which one to give? See, the cough chapter, first of all the time is given, the arrangement is there where we know that site, time, modality, extension, location is there. So the sites are given, then the modalities are given. Then if we have to type, I think so many screens have opened here. So if we have to type like See, throat or larynx, which part is affected? So we have to search for dry. So dry cough, so many remedies, but how do we know which one to be given? So we put on all the symptoms which the patient presents to us. Like I told you, lying aggravation. So see, if we click on lying, we have symptoms, amelioration, aggravation. So like this, when we study all the rubrics, then only we'll be able to know how many rubrics. See, you can just go through this: cough mental exertion from, cough metallic sounding, cough paroxysmal, cough persistent. I was telling you these things. So if we go on to the paroxysm further, let me show you. We click on this. See, painless, palpitations aggravate, panting with the cough. Now we click onto this paroxysmal thing and see. Paroxysmal cough when daytime, night, evening, with expectoration, lying while, lacrimation. So many sub rubrics have opened up. Then paroxysm, pay attention to this. Paroxysm of short cuffs, paroxysm of 3 cuffs, paroxysm of 2 cuffs, violent spells of coughing. So every symptom has been given in the repertory. We just have to locate it out and we just have to question our patient so that we get enough information so that we can prescribe beautifully to our patient pertaining to his presenting complaint. So come on to the expectoration again, the morning, evening, afternoon. Now we have the color of the expectoration, right? We have the consistency of the expectoration. So everything you will find here, yellow, right? Brown. See, repertory is something like you name it and you have it, right? So everything you will find starts like sticky, sweet, thick expectoration. All the synonyms are there. Simple English language synonyms are there. And then coming on to the respiration thing. This was all pertaining the cough plus other diseases where the patient has expectoration, where the patient has chest complaint. Now we are coming to the respiration chapter, where we have symptoms like difficult breathing, the patient presents with us, we have asthmatic patient. So how do we differentiate that? Okay, asthma means difficult breathing. All asthmatic patients come up with the complaint of difficult breathing. So when this difficult breathing is occurring, how they are getting relief of this difficult breathing, this becomes important. The modalities differentiate the things, and we have all written in our repertories, and we can check from this. Again, larynx and trachea is there. Okay, so we have opened the respiration chapter. So see, respiration problems, the time of the day is written there. Respiration difficult. We'll have further all modalities listed to this rubric as I was telling you. Then the position of amelioration, bending forward, bending backwards, lying aggravation, motion amelioration, motion aggravation, everything we will find here. So repertory has an important role to present in not only just these diseases we are discussing, but every disease, provided you get good clear sign and symptoms. And it is all about individualizing, because repertory is a tool which helps us to reach to this. See, so many remedies have been listed here, we cannot remember all by heart, so we just take a help. It is a tool. We put the rubrics and we get out the result. We compare with our knowledge of materia medica, and then we prescribe to the patient and see how beautifully your patient recovers. So this is all about the importance of repertory in case taking of respiratory infections. So hope this much is clear. So for how to take the case for respiratory infections, you have to refer to the repertory, because unless and until we know from the knowledge of our medicine what are the signs and symptoms of presenting clinical condition for particular diseases. But in that diseases, what we have here in our repertories. So that we will know only when we know the chapters, we know the rubrics of the repertory. So go through them well so that your case taking will be brushed. More precise it will become. See, excitement, emotional aggravation. So it excites the breathing problem. So exertion aggravates. So exertion excites. Mentally nahi, physically. Then expectoration ameliorates the patient. Whenever he has some expectoration, the breathing is relaxed. So fan being amelioration, fever during difficult breathing, flatulence with. So we won't, if I ask you, you won't remember difficult breathing, flatulence from, you won't remember which is the remedy for this. But here, see, we have so many remedies listed here. Flatulence incarcerated with. So if I ask you like this, nobody will be able to remember all the remedy. Maybe we'll able to tell one or two. But see here, respiration gasping, heart complaints with, headache with. So all these important symptoms are here, which you can learn only when you have the knowledge of repertory. Thank you so much.